going to go ahead and lay up on the table. We've already done the scalp now. We've got the scalp checked and it's clear, so we're ready to go. Okay, so we're going to start your procedure. I'd like you to go ahead and turn up onto your left side. I'm going to be putting a tube into your rectum.
Yes.
La voy a dar una laventiva. Right? That's the best I could do with them. Doesn't that mean like I'm going to give you something to wash or... I don't even know the direct translation to that. Here. Okay, so I got to get my gloves. Got to get my surgical lube. Usually the lubrication that some places will have like these pre-filled packets. This is actually bigger than I've seen. It's usually about half the size that you just open up. Or you just want to put about a quarter size if you have the regular tubes. Remember, you don't want a lot of lubrication on the tip because if you put too much on this end, then it's just going to slide back out. You only want to lubricate the front end of it. One thing I didn't mention this morning that I just thought about too is I've worked in some places where we actually have a lubrication that's a xylocaine lubrication, so it has a numbing effect to it. I'm not sure if that's good though, because if you numb up the area, then they can't feel when the tube's starting to slip out. But people that have severe hemorrhoids, we would use it for them to kind of ease the pain of their tipping. Okay, so you always want to put gloves on when you're tipping, obviously. And the thing is with the gloves is, once you tip, if you want to wear gloves during the procedure, you should take your gloves off after you've tipped and go put some clean ones on. It drives me crazy when I see people walk around in the workroom. Gloves are all messed up.
Do this?
Huh? I don't want to blow. Oh. They walk around with gloves and you don't know where those gloves have been. You know, are they clean gloves or are they dirty gloves? That happens a lot too. Okay, so I'm going to have him go ahead and bend his knee forward so that it exposes the area. So it's nice to get a sheet or something so that you just have the area exposed, you know, and you're not laying there half naked. Put a little bit of surgical lube on the paper towel. Tip already. Okay, sir, I'm going to have you take a breath in. Now remember, we put the tip in, we point towards what?
Your belly button.
So don't point up too far this way or too far straight in. That's not going to be comfortable. You have to push it towards the belly button. So take a breath in. Blow your breath out. Okay.
There we go.
Okay, try to take slow breaths. You have some take it there this way. Last time we lost our tip.
If you want, I'll hold it.
You put it in on the breath in?
As they blow out.
Oh, I see.
So breath in, and as they blow out, you push the tip in.
I heard that you put it in, the sphincter actually like sucks it in.
It does.
Yeah.
It can, yeah. So, but you only want to go to this little notch here. You know, you don't want to try to force it past that. But you do want to get it past the sphincter so that when you go to inflate the balloon, you try to inflate this balloon and it's only partially, and that's going to be really painful. So, okay. Let's go ahead and tip it there. All right. So now I'm going to get my, where'd my blue ball go? Oh, yeah. Okay, so I've got, I want to make sure that my tubes are not coiled. Okay, so now, sir, I want you to just breathe slowly for me. Now, if you go to inflate this and they start really going, that means you probably don't have it in far enough. So you might want to just gently push it in just a little bit farther, inflate the balloon.
They do that, right?
Yeah, they do. They kind of jump. Okay, so then clamp it. So once you let go, the balloon is not going to deflate. Now, typically, what I've seen done, and I think Erica mentioned she's seen people put this up to the put oxygen tube on it, but maybe just shake it. Just in case, now we've done this because the radiologist is in. If the radiologist isn't in, I wouldn't tip him yet. You have to find out what your doctors want, because I've been in places where if the patient's not tipped when they walk in the room, they'll walk out. And I've also been where I've tipped a patient and I've waited 45 minutes for a doctor to come in. So, you know, it might be where you put the tip in but don't inflate the balloon until the doctor comes in. And in some places the doctor wants to inflate it in the floral. So you have to find out what the routine is for your hospital. Okay, and you work with a lot of different radiologists, and they all have different.
So as students, can we tip?
You can, yes, you can start practice tipping now. With supervision. Okay, so then they may decide to inflate this some more. Oops, this just came off. It was too much. And I'm afraid if you do this more than one time, you have a risk of... Look how big that balloon is. Okay, so now it's going to act as it's going to act like a cork in there to keep the fluid in. Okay, so now the doctor's in. We've started the procedure, so he's going to say barium on. So I'm going to go ahead and then move this back a little bit and let it run. Okay, sir, turn on your stomach. Turn on your back. Turn back on your stomach. This is all a little bit too. Okay.
It's gonna be.
Turn over onto your right side. Go all the way over on your other way.
Anyway.
Go on your stomach and then on your right side. And now back on your left side. Now see what's going to happen? No, keep rolling. All the way front, Papa. See what happens is the tube's going to start getting all wrapped up, so you have to really watch the tube. Okay, now go ahead and turn over on your left side again.
That's.
So now we got to get this tubing all untangled from his legs. These up. We're taking
I'll just hold it.
Yeah, okay. So let me have it for a second. Okay, now hold on. Okay. So now we coated and tested. So now we're going to let the barium out. So before you put the bag on the ground, make sure the cap is tight. Okay? And then also, we unclamp it and let the barium go. So now the barium's coming back. I usually don't watch it because it's kind of gross, but you may want to kind of squeeze the tube, and gravity will just help it come back out. And so then it'll fill about halfway, and then the doctor will say, okay, I'm ready for air. Before you start putting the air in, you need to clamp the tube. If you don't clamp this and you start adding the air is going to go into the bag. Yeah. Again, you may have him turn on his side, turn on his back, turn over several times, to coat all the walls of the intestine. Okay, so the doctor's done with his overheads. We're ready to start. Done with his spots, and now he wants his overheads. Okay, so you just bring the bag up onto the table. Put on some clean gloves, or maybe no gloves. Usually clean gloves, just in case they start to lose it. You can have something covering your hands. Okay, we're going to start your overheads now. So I'm going to have you go ahead and turn on your back for me. Okay. First picture, AP, just like a KUB, 14 by 17, lengthwise, lights down.
George.
Lights down.
So we do our first overhead with the tip still inside?
Yeah, usually we leave the tip. It depends on the patient. If it's a very young patient that has no problem with the control, I may take the tip out for comfort. But for most people, the tip staying in will help them hold the fluid in. So I'm going to keep the tip in for now. So I'm going to center epithelial crest, 14 by 17. I could shield, although frankly most of the time we don't shield doing BEs because of all the turning and twisting, but since he is a young male patient, we do want to shield the gonads. Okay, taking a breath, blow it out. Okay, you can breathe. Okay, next picture, AP axial. Change your cassette, 10 by 12. 10 by 12.
That's all.
Okay.
Okay.
I'm feeling this light's going out. Yep, I think it just went out.
Oh.
Let's see if this is... Great, now I gotta change the light bulb. What is this? Oh, that's odd. Maybe it's just loose. Yeah. Okay, so where do I send it for the axial? Depending on how much I angle. If I'm only angling 30 degrees, it turns out to be about an inch below the ASIS. Because what you want is the line here bisecting through the ASIS. So where my finger is the ASIS. See how the line is cutting through on the side? Bisecting through on the side? So if you actually look at the line where the ASIS is on its body, it's about an inch below. That's at 30 degrees. But if I'm doing 40 degrees, then it would be 2 inches. Because it's more severe of an angle. See the difference? So let's, for now, leave it at 30. It'll depend on your hospital's protocol if they want 30 or 40 degrees. So column 8, 10 by 12. So this is just for the sigmoid. I'll show you the butterfly at the end, an additional view. Okay, so that one's done. Change my film again. Why do you think I'm going so fast? Because the area can only see inches. That's right. All of my films, 14 films under 10 minutes. 14 films under 10 minutes. Okay, go ahead and turn towards me. Back. So this is your oblique abdomen. So you want to make sure and center at the iliac crest, and then the side to side is just halfway between the abdomen. Now, for some of you, we'll have to check if you fit on a lengthwise film or have to be crosswise. For some of the guys, we've had to do it crosswise, and we've had to do upper and lower. But the way you really look is come to the head and look at where the abdomen is, and you center right in the middle. For him, it's about an inch up from the MSP. For someone who's wider, it might be 2 inches up from the MSP. Okay, this morning we had actually 3 or 4 people that were more hyperstenic. I think we have more variety in the morning class than we do in the afternoon. The idea is that you need to have the light just to the, because which flexure are we demonstrating here? So we want to include this flexure, but we don't want to discount the abdominal tissue that's on this side either, because we're trying to image the entire colon. Because the radiologist has already done his individual spots. He wants to see the entire colon at one time. Okay, so RPO.
45 degrees.
45 degrees, yes. LPO. Onto that tip. There we go. Straight. Okay. So I'm at the iliac crest, and I'm halfway, like 1 inch above on him, 1 inch above his MSP. Because you want to get this side of the tissue, and I'm going to show you hypersthenic when I'm done too, so you can see how we center slightly differently. So I've done the AP, the axial, the RPO, the LPO. What's next? Lateral. So go ahead and turn up on your right and on your left side. 10 by 12 for him. If it was a male, larger male, I mean, say if it was a male, you're a male, but then it would be 11 by 14. Block her up, block her down. Probably doesn't really matter, block her up, because the rectum's going to go back down like this. Okay. Where do I center for the lateral? Iliac crest and MCP. So, MCP. It's not iliac crest, I said you said ASIS. And it's actually just slightly below the ASIS. That's right. Here's this trochanter. You want to be right above the trochanter. I'm cautioning you too. In the BEs, we don't usually use sponges. You know, you can use sponges in this class, but if you get barium in this sponge, you'll never be able to use it again. It won't be able to get washed out. Okay, so it helps if you flex their knees, because you can imagine where the bend of the gluteus is here. That's where the rectum's going to go out here. So it goes out, curves around, and goes anterior. Make sure they're nice and lateral.
Is this on respiration suspenders?
Expiration.
On expiration.
Yeah.
So what
Down
do we
here
use?
doesn't matter so much, but you might as well stay consistent.
So what do we use for the RPO and LPO if without sponge?
What?
I mean, to elevate the...
You just have them hold it.
Okay.
Because you're moving so fast. In a real situation, here, you can use the sponges. But I'm saying, in a real situation, you shouldn't use the sponge because it's going to get barium on it, or could potentially. Okay, so that's my my left lateral. What's next? MCP. What's next? Come on, you said I'm in the barium.
Right lateral.
Right lateral what?
Decubitus.
Yes. But what side is he on?
Right.
What side is he on
Left.
right now?
Left.
So wouldn't it make sense to do the left lateral decubitus since
Yes.
he's already in that position?
Left.
Right? Remember, think about your patient's position. Okay? Move my tube over here. Okay, so I'm going to have you go ahead and raise up. I'm going to put a pad into your side. And there went the tube. Okay, now one thing about the rectum, you'll have to find out, they may want you to at least deflate the balloon and not leave it in if it's going to show the rectum. Because they want to see the rectum, not the balloon. Okay, so that's another thing. You're going to have to find out what the protocol is for your place. Okay, can we go around and do the tube? Okay, where do I center for the decubitus?
MSP.
Horizontal.
And iliac.
Right
Yeah,
at the
and
iliac crest, it's scotch below.
Scotch below.
Watch out, Tam. Central raise right where my finger is. Straighten out your legs just a little bit. Scoot back towards me slightly. Okay, good. Now, as far as my markers, did you find that other marker? It's on it. Oh, okay, I left it on here already. So, which side of the body is this?
Right.
Which side is this?
Right.
So if I'm going to mark the up side, then I'm going to put my right marker here and then put an arrow marker or an up marker. We seem to have lost again. Okay, take a breath in. Blow it out. Hold it out. Stop breathing. Close. Okay, good. We're almost done. How you doing?
Horrible.
Okay, we're almost done. You're doing really good. Go ahead and turn over on your other side now, facing me. So I've changed out my cassette.
Just do it PA instead of A.
See, instead of moving your tube around. Right? Again, notice that this almost happens every time. When they turn, they slide up or down. They won't be exactly in the same position. So here's this iliac crest, okay? Is that okay? Yep, okay. Taking a breath, blow it out, expose. Okay, what's left?
The ventral decubitus.
Right. So the cross table lateral rectum or ventral decubitus. So go ahead and lay flat on your stomach for me. Now you may or may not need a pad. For most people you don't need a pad. Because because the knees lower. Watch out.
Thank you.
Now, one thing I want to show you, though, if the patient is, well, let me show you this one first, and then I'll do the second part. Okay, so where do I center for the lateral rectum?
I'm going down again.
MCP and ASIS. It didn't change. My centering point didn't change. The only thing that changed was the direction of the tube.
For the right and left lateral decube, just push this all the way back there too.
Yeah, you want to try to get 40 inches. Okay, so, and I can show you with my hypersensitive tube. Yeah, for him. But this is what I'm going to show you. Can you raise up a second? If he is exceptionally large, the higher his abdomen is, or the thicker his abdomen, the higher his abdomen is going to be. So you may see, does this look like this is going to work?
No.
Probably not. So what do you do?
Lift up the cassette.
Remove this one.
Well, we're pretending the sponge is his abdomen, though. So we can't do anything about that.
Use a
you
bigger
managed to get a
cassette.
bigger size
Cassette.
cassette. So in this case, then you'd get 11 by 14. Now, we don't have 11 by 14, so you either get 11 by 14 and say you're going to use a grid. Oh, that's still a 10 by 12. Or you use a 14 by 17 and collimate down to 11 by 14. Oh, a position of blocker should be south.
Down.
But it's, see, I'm thinking up because it's actually up towards the sky, but it's down towards the patient's feet. We had this discussion earlier. So this way we're sure that we're going to get the rectum that goes posterior. And don't get too thrown off because they're going to have, extra soft tissue back here that it's not going to affect where the rectum is. But you want to make sure that you can center to the MCP here. So funny. You put your finger right where my crosshair is. Right here. I can do it in the dark. And ASIS. Okay?
And this is either 10 by 12 or 11 by 14?
Yeah, depending on the patient's size. But you have to have a grid. But you must have a grid because of the thickness and the contrast. Okay, sir, go ahead and turn up on your left side for me. You did really good. Your pictures came out, and we're going to get ready to send you into the bathroom. So now I'm letting the barium drain a little bit into the bag. Okay.
Butterfly.
Okay, well, I'll do that. I thought I'd let him drain.
Oh, okay.
So wait, like, before we take our scouts or our overheads, didn't you drain the barium already?
No, overheads
Halfway.
are full with barium.
Oh, okay.
She drained a little bit
I
to push the air in.
Yeah.
Oh, okay, gotcha.
But now I'm letting whatever air and leftover barium is going to come back in the bag.
Oh, okay.
Yeah, that's a good point. They may have already drained some of the barium.
Okay, and how,
Go
are
ahead,
they going to
turn
tell
on
us
the
how
bag.
much to drain, or
No, usually you just wait till the bag fills up a little bit more.
the
Or
first
the-
time, I mean, the first range?
The doctor will see it on fluoro, so he'll know when to stop.
Oh, gotcha.
Okay, let's go ahead and show the butterfly before I send you to the bathroom. So the butterfly axial is what? What is my angle and degree of rotation?
30.
30.
30.
So I'm going to rotate the 230 degrees, and I'm going, or angle to 230 degrees, and I'm going to rotate him 30 degrees. Which direction?
Oh, oh.
RPO?
Mm-hmm.
LPO.
Oh, yeah, towards his left.
LPO.
LPO. So remember, you want to use this side of the sponge, because that's 30 degrees, not the 45 degree angle. Okay, so see what happens when he rotates here? Watch the table. Okay, let me go back to the AP. See when I'm centering for the AP? Good job, 'cause I can't watch you and him too, so. Okay, so this would be the AP axial. So when he goes to the left, where's the colon going to go? Where's the cecum? I mean the sigmoid. Towards the left. So you want to make sure it's center towards the left. Because remember, it's going up and then bending this way. So at this point, the central ray is basically at the MSP or just to the left of the MSP, depending on the patient's size. If the patient was really big, if they had abdomen all the way over here, then you'd have to center over a little bit more. And maybe even use a bigger film. But on a small patient, you can... So here's this MSP, so I'm basically just off center slightly from the MSP, but you want to make sure you've got the left side. This will not work. See that? If you do this, the colon's going this way, you completely missed it. Okay? You want to make sure to center slightly off to the left to get the sigmoid.
So if you just got light skimming on that side,
Yeah, if the light skims here, is that what you're asking? Yeah. Okay.
so it's
On
supposed
the
to skim.
marker, where you put the marker on the side, so.
Well, because I'm doing the LPO, I'd probably mark the left side. Okay.
So light is supposed to be skimming on the side, or it doesn't have to be?
Well, it depends on the patients. If they're acute, if they're super large, it doesn't have to skim on the side because there's going to be some adipose tissue. But someone small like this, I would have just at the MCP. But you'll see hypersthenic in a minute to understand what I'm trying to show you as far as where we position the light. But a hypersthenic patient, the colon's probably going to go off to the side farther than a sthenic or asthenic.
Is this going to be blocker down?
Yeah. Because the blocker down, we'll put it here, and the rectum's going to go up in this way, so it won't get in the anatomy.
And this is at the ACEs, yeah?
Yeah.
At the ACEs
Well,
right left,
if-
and then slightly off to the left.
Yeah, so it's skimming the ACEs from the side. You like if you feel where his ACEs is, it's hitting the light right here.
Uh-huh.
But the actual centering point on his body is about an inch below the ASIS.
Okay, yeah.
If you're 40 degrees, it's about 2 inches below.
Okay.
Okay, turn up on your side for me.
So what is this than this?
For some people, some hospitals like this one because they think it opens up the signal more. Go ahead and turn up on your left side. Okay, so now we've drained the barium. We're going to clamp the tube off. I'm going to put my gloves back on, get my paper towel. Okay, before I let him get up, I'm going to take the tube out. If he's really having a hard time holding the water, or the barium rather, we may leave the tube out in until we get him into the bathroom. Because it'll help act as a cork, so you'll have this spray of barium on a trail from the table to the bathroom. And you'll know by then. I mean, patients will be leaking or they'll be having a hard time. I'm going to get the tube up out of the way here. Okay, so if I was going to take the tube out now, I would take off the inflator, put it over here. Next thing I want to do, get my bulb and put it to the side because we reuse those. Don't throw them in the trash. Now before I try to take the tip out, I need to release the bulb. Don't try to take it out with the bulb inflated. Okay? Although sometimes I've seen when it's fallen out with the bulb inflated. Yeah. Okay, so I'm going to pull it out, take a breath in, blow it out, and then you just wrap it up in the paper towel. And then the whole thing, make sure you got the tip down and throw it in the trash. Okay? All right. If we have to keep the tip in because he's having a hard time, go ahead and hold on to the tip. Okay, so I'm going to have you sit up for me. Turn over on your back. Go ahead and sit up. Now remember, they've had nothing to eat or drink for a while. You want to wait a minute. Watch your head. Don't let them just jump right up and go into the bathroom because remember the vasovagal I mentioned? That people will have a reaction and this is where they could faint. You want to make sure they're okay. You feel okay? Okay, let's have you get down. And then we're going to help them this way. Right? Okay, Tina, you're on the toilet. Oh. Okay, now I'm going to release the bulb, pull out the tube, and then let them sit down. Okay. Close the door. I usually leave the door open just a little bit if it's an elderly patient. You want to give them their privacy, but you also want to make sure they're not going to faint or anything while they're in there. So you want to kind of keep a earshot, eye shot on them. I did have an elderly patient one time who was Korean, so we were having a communication problem because she didn't speak English. She had a stroke while she was in the bathroom evacuating the barium. And so when I went in to check on her, she was suddenly kind of leaning over to one side, and I thought, what's wrong with her? I don't remember her being like this before. So I brought her, I had a hard time getting her to stand up, so I called for some help, and we got her, kind of carried her into the table and took her post-evac. Well, her family was outside waiting, and what do you think? They thought that we caused her to have a stroke. And it was probably coincidence that just at that moment in her life is when this infarct happened. But that turned into a big, long legal thing that I was involved with because they wanted to make sure that there was no, substandard quality